A very warm good evening to all. I am Dr. Rahul Sen, consultant embryologist from Neelkant Fertility, Jaipur. And for next few minutes, we'll be discussing on failed abnormal fertilization. So, just to begin with, what is the fertilization? Fertilization is a series of dynamic and complex events that are triggered basically by sperm and oocyte interaction that leads to the formation of a zygote. Zygote is basically formed with the interaction of oocyte with the sperm, and then as a resultant product of fertilization, the zygote is formed. Basically, these two major ingredients which are required for the purpose of fertilization, that one is the oocyte and other is the sperm. Oocyte is basically providing the structure to the developing embryo, and it is said that good quality of oocyte will ultimately or eventually develop into a good quality embryo. And for that good quality oocyte, a sperm is needed to fertilize, which is a good, normal, healthy, morphologically normal sperm that ultimately fuses with the egg and forms the zygote. So, what happens during the process of fertilization? When we are talking about the process of fertilization, naturally, the sperm uh, moves from the male reproductive tract from the male reproductive tract to the female reproductive tract, and finally it recognizes the oocyte and fuses with the egg. But the same thing doesn't happen in the assisted reproduction. In ART, when we are talking about the conventional IVF, the number of spermatozoas are allowed to release in the culture media where the oocytes are present, and out of that, only one single spermatozoa has the capability to fertilize an oocyte. And in cases where the sperm doesn't has the ability to fertilize an oocyte, with the help of ICSI, a single good quality, healthy looking, normal morphology sperm is selected and then transferred into the center of the cytoplasm of an egg. So, and as a result of fertilization, the zygote is formed, and these particular and the events of fertilization includes sperm penetration, sperm oocyte fusion, oocyte activation, male and female pronuclei development, and gradual migration of pronuclei. These are the pronuclei to the central position of an oocyte, and that to be followed with the cleavage divisions. So when we are talking about the embryo development in ART, basically the phase of embryo development is correlated with the morphology, that is the morphokinetic parameters, that is the morphology, and the kinetics, means the time of the development. And on the day of ovum pickup, that is the day 0, followed by the day 1, 2, 3, 4, and 5 of the successive days of embryo development. The very next day is the day called as fertilization check, where the pronuclei are seen. The PN structure or the fertilization assessment is done. And later on the stages, embryo is developed, and then further processing is being done. So coming on to the topic which we are discussing on the fertilization, on day 1, that is the 17 plus minus 1 hour, which is mentioned and described by the Istanbul Consensus in 2011, the fertilization check is basically an initial step of assessment. This basically assessment is being done of to check whether the zygotes that are formed as a result of fertilization, they are normal or abnormal. And this particular assessment also helps us to verify whether the embryoploidy configuration is also normal or not. So let's see how to differentiate a normal and an abnormal fertilized zygote. So according to the definition, a normal looking zygote will be assessed by the presence of two centrally positioned juxtaposed pronuclei. You can see in this particular image, there are the two pronuclei of almost even size. They are juxtaposed to each other with clear defined membrane and number specific nuclear precursor bodies. Can you see this image clearly?
Yes, sir.
So this is particularly the image of pronuclei. One pronuclei is being provided by the male cell, that is the sperm cell, and other pronuclei is being provided by the egg cell, with the number of nuclear precursor bodies and well-defined extruded two polar bodies. These are the two polar bodies. So according to the definition, this is particularly a normal looking zygote. And what can be the abnormalities in these zygote formations? That can be post fertilization, no pronuclear structure seen, only one pronuclei seen. It can be seen as three or more pronuclei, which is again an abnormal form, and the pronuclei with positional abnormalities. In this particular image, it may happen as rested on the pronuclei stage. Here you can see uneven pronuclear size. One is very much bigger and other is very much smaller. Other in this image, you can see they are not centrally located. They are shifted towards the periphery. And here there is a misalignment of pronuclei, means they are not juxtaposed to each other. So how these abnormalities can be of different forms or can be of abnormal forms in ART. Let's discuss about them. So if on day one of IVF, we see eventually a single PN zygote, means only one pronuclei is seen on day one of an IVF cycle. That can basically result in 2 to 5% of IVF cycles. And this mechanism is also being said that it may be due to asynchronous appearance, means we might not be able to see two pronuclei. These can be like this and we are watching like this. So it can be due to asynchronous appearance, or the fusion has already been done if it is a normal looking zygote. So we might end up in looking it as a single pronucleate zygote. And generally it happens in ICSI that if it is seen only one PN, means only one pronuclei in the zygote, that can be an indicator for the majority of oocytes that might not have activated but they have fertilized. So this particular pronuclei may have been provided from the sperm. And if there is no other choice with the embryos remaining, the transfer can be proceed, and this particular embryo may lead to a good outcome or the pregnancy. But if we see 3PN, means more than two pronuclei, the third pronuclei or the four, it can be more as well. So if the pronuclei are more than two in number, that is basically most common fertilization anomaly that can be seen in an IVF, when we are conventionally placing the sperms near the oocytes, and these oocytes are allowed for the fertilization and they allow one or more spermatozoa. Then as a resultant of product of the fertilization, there can be seen 3PNs. This is mostly caused by dispermy, that is due to more number of sperms which have entered in the oocyte, and majority of corresponding embryos will cleave. They will undergo the development. They will undergo the phase of all the phases of embryo development, but eventually they will either arrest at some or the other stages, or if they turn out into if they do not means arrest at the remaining stages, they might not give a good outcome. So post ICSI, if we see 3 p.m. zygotes, that is basically in the 4% of the IVF cycle. That can be also happen due to digenic triploidy. That means uh, that a single sperm is present in the egg, but the second polar body is not extruded, and that polar body has been not extruded due to non-disjunction of chromosome during the meiosis part of division, and that particularly resulted into a secondary, means another pronuclei. So these, if we see on day one, more than two pronuclei, these particular embryos are not suitable for transfer. They should not be transferred. They should also be, if they are cultured, they should be cultured separately from the from the normal growing cohort. And the other abnormalities, like we have discussed, the peripheral positioning of pronuclei, misalignment, uneven size of pronuclei, or no visible pronuclei at all. So these kind of pronuclear stages should be correlated with the later ongoing embryonic developments, and then only selected for transfer. In literature, there is a plethora of publications that has been done on morphological aspects and zygote scoring. Major widely used scoring systems are being proposed by Tessaric and Greco in 1999 and Scott et al. In 2002. Ultimately, it came with Istanbul Consensus in 2011 that gave a huge impact on embryo scoring as well as the pronuclei scoring, which was ultimately based on the morphology of nucleolar precursor bodies and the shape and size of pronuclei. So according to this Istanbul Consensus is in 2011, they have proposed pronuclear scoring in three different phases. One is the symmetrical, other is the non-symmetrical, and third one is the abnormal. The symmetrical form of zygotes present with equal number and size appropriate nucleolar precursor bodies. Either they are aligned or scattered in the pronuclei. The non-symmetrical form of zygote morphology comprises of all other patterns, including peripherally localized pronuclei, and the abnormal form includes single nucleolar precursor body or no absence of NPBs with the uneven shape and size of pronucleus. Here you can see the pronuclear shape and size is eventually larger than what we see in the normal forms. So all these parameters to be appropriately checked appropriately at the fixed time of the development. As you have seen in the previous slide, that embryo development is morphokinetic based, means morphology is there and the kinetic part is also there. So all these pronuclear grading has to be done on time specific event. So these pronuclear scoring has the clinical significance as a zygote's morphology characteristics are expected to be inherent indicator for both gamete quality and as well as subsequent embryonic growth and implantation potential. Many studies have already underlined the predictive value of zygote morphology assessment through correlations with chromosomal constitution and the incidences of zygotic arrest. The recent strategies in embryo selection include sequential morphology assessment, where pronuclear scoring has shown to play an important role as an indicator not only for the gamete constitute, what we were discussing earlier, but it has also shown as an impact, as an strong predictor for embryonic developmental competence as well. And the another form of abnormal fertilization, which is most dangerous, I would say a nightmare for an embryologist or any ART practitioner, that is the no fertilization at all. Means we have done all the work, we have done the fertilization on day 0, and on next day coming on to the morning, early morning, and seeing No PN at all means the sperm has not eventually approached the egg conventionally, or our technique of XC, which we have done a day before, that has not uh, eventually produced a zygote. So this is particularly a nightmare kind of situation for each and every one of us. Before proceeding towards the identifying the cause of no fertilization or why this fertilization couldn't happen, we need to understand the biochemistry or the molecular. We need to understand the fertilization at the molecular level, how basically it goes on, and then eventually we see a good pronuclear on the next stage, because you can see the oocyte is basically fully compressed with the organelles and the other chemical components and the pronuclear genetic material within that. So as a process of fertilization where a sperm has already penetrated the egg, and the sperm will ultimately allows its nucleus to release inside the oocyte. Sperm not only releases the nucleus, it also releases the centriole, and with that centriole there is a chemical, species specific chemical or an enzyme, what we can say is, that is the PLC zeta. This PLC zeta enzyme hydrolyzes a further cascade of other enzymes that basically helps in relieving or releasing calcium from the smooth endoplasmic reticulum, and this particular calcium is being released at different levels of spike. This particular spike at different intervals is known as calcium oscillations. This calcium released is being released in the perivitelin space of an oocyte that will ultimately work in two different ways. In one way, it will block other sperm to enter in the oocyte, and the other way, it will ultimately activates the oocyte. It will activate the oocyte to get fertilized, that yes, the sperm has entered, now you have to activate yourself, and then the fertilization as a process will begin. So coming back to no fertilization, that yes, there are the evidences that says only 70% of the fertilization rate, that is the competence value, is seen in IVF or in XC cycles. However, no fertilization or total complete fertilization failure is also seen in IVF and in XC cycles, that even if we are having good quality normal looking sperms or good quality normal looking oocytes with very good ovarian response, even then also we can, yes, we can see no fertilization on day one at all. So the literature has revealed, yes, there are the symptoms or the causes has been found, that how this fertilization failure has occurred. And this fertilization failure has occurred, or the defects can be seen from the oocyte factors, from the sperm factors, and even also from the technique based factors. The oocyte factors that can be due to, if we have frozen thaw the oocytes, then it may cause for a total fertilization failure. If the oocytes are in vitro matured, if the patient is already poor, already suffering with poor ovarian response, or we have retrieved less number of oocytes in that particular cycle, or the patient is already genetic inherent with this particular kind of disease, in that cases, in those situations, we might expect, or we may see total fertilization failure on day one of that IVF cycle. Same with the sperm factors. If the sperm chromatin status is abnormal, a complete globospermic sample, or the globo or the round-headed sperms are seen in the ejaculate. If the sperms are surgically retrieved in that situation also, if the sperms are if that particular male partner is suffering from severe OAT, that is oligoasthenos teratospermic sample, and again the genetic defect if it is there. And with the technique based factors, like there was already a previous cycle, we have already seen poor fertilization or no fertilization, and in some cases of unexplained infertility. So all these factors club and accumulate into the major defect of total fertilization failure. So what is the process or what is the physiology behind this failed fertilization? So soon after the ICSI, it was first, earlier it was speculated that perhaps the proportion of unfertilized oocytes arises due to the technical limitations. Means all each and everyone was stating that no, the technique is not good, no, the technique which you have performed is not good. So it was all blaming the technical limitations, that yes, embryologist might have done something wrong in the lab, he might have not done the process or the technique properly. So everything was going on to the embryologist or onto the technical part. But it it was proved, or it was like done or visualized with the different staining technique, that the majority of unfertilized oocytes were arrested at metaphase 2 state with the different level of sperm chromatin decondensation. Generally, a sperm which is delivered into the cytoplasm, it ultimately progresses with the chromatin decondensation, and the level of chromatin decondensation further proceeds into the pronuclear formation. That if the sperm is ultimately failed in chromatin decondensation, then the basically technique is or the term is called as premature chromosome condensation, where the condition when sperm chromosomes are getting condensed in the cytoplasm of an oocyte, but there is no synchronization between sperm and oocyte genetic material, and it can be seen in up to 33% of the unfertilized oocyte. Even from the oocyte factor, oocyte activation failure might have been the cause, and it is already seen from high grade microscopy, like electron microscopy, where unreleased cortical granules were seen at the periphery. Maternal chromosomes were arrested on the metaphase plate, or the paternal intact or partially decondensed. So these all were the signs of failed oocyte activation, and it is difficult to conclude on which level the cascade there seen a failure. Then, to rescue this particular event of total fertilization failure or the oocyte activation, there comes a savior for each and every one of us, that is the artificial oocyte activation. What we can do is we can artificially activate the oocyte, and then we may feel like yes, may be able we may see fertilization on next day. So this oocyte activation is a downstream cascade triggered by sperm that causes progression of oocyte from the arrested phase to the further embryonic developmental phases. There are the different procedures or the techniques, what we can say, yes, by which artificial oocyte activation can be done, and that can be done either mechanically, electrically, or chemically, which is the most dependent portion of artificial oocyte activation, which is basically available commercially too. That is the chemical forms which are being there available in market. Yes, artificial oocyte activation that can be done electrically. Uh, in this particular form, the typical pattern in calcium rise is seen or induced by electroactivation or a single electric pulse. It has been reported that around 70 to 80% of unfertilized oocyte have responded to electroactivation. Mechanical form is basically a modified ICSI technique, where the during the process of ICSI, it is being done in such a way that the highly polarized mitochondria are released onto the site of sperm injection. And this particular site of injection causes the influx of stored calcium in the endoplasmic reticulum that is then set free, and again on next day morning you can see a good looking pronuclear embryo, and it can be done mechanically, that is artificial oocyte activation. The most commonly used or most available form of artificial oocyte activation is the chemical stimulation. These chemicals are briefly exposed to the injected oocytes, and these chemicals do not appear to be cytotoxic when they are used in an optimum concentration. So particularly commercial, because of the commercial availability and everything, these chemicals are easily available in the market, and with that particular procedure and protocol, eventually oocyte activation or the failure of fertilization can be avoided. But just to, I think it's a warning sign, or just because of the unavailable literature, these agents must be limited or to be used in proper indicated cases, as their potential cytotoxic, teratogenic, epigenetic, and mutagenic effects on oocyte and developing embryo are not very clear. The literature is very much deficient on how these particular embryos were grown, how these embryos implanted, and how these implanted pregnancies converted into a healthy babies. So it is to be done with the limitations or on the proper indicated cases. To summarize, yes, fertilization is an extremely complex phenomena. Total fertilization failure can occur frequently, or it can be a total loss of cycle. A major cause can be due to sperm oocyte, or with the technique. We have very much little understanding with the process, and there is no current remedy for oocyte specific causes of failed fertilization. So coming up with the conclusion, pro-nuclear morphology assessment can predict embryo development and outcomes in ART cycles. The scoring criteria is very useful tool in selecting the most suitable forms of embryo for transfer. In cases of repeated implantation failure and in cases of blastocyst cultures, where we are culturing embryos till day 5, and where we have seen already previous fertilization implantation failures, it is very appropriate way to select embryo starting from the day 1, where we can select and eliminate the abnormal embryos that are due to abnormal chromosomal conditions. Thank you. So if there are any questions available to answer.
One question in your last slide, like this extended culture, it means that till blastocyst.
Till blastocyst, yes.
Oh.
Because what happens is ultimately during the phase of blastocyst development, many of the embryos do not turn out into blastocyst. So if we are looking embryos only on day 3 or only on day 2, then it is not good way to expect that yes, all these good looking day 3 embryos may turn out into a good looking blastocyst. So it is eventually the sequential way of embryo assessment, means on day 1 we need to assess, day 2 we need to assess, 3, and ultimately the cumulative development or cumulative grading that will eventually help us in deciding whether we need to go for blastocyst, or whether we can expect or we may expect that yes, out of these embryos blastocyst formation can be seen.
Sir, one question, that total fertilization failure is more common in XC.
No, it is not more common. eventually the competence value of fertilization with ICSI is near to the 70%. So there may be chances of having no fertilization. It is not total fertilization. It may be like you have retrieved 10 oocytes, and out of that 10 good quality
Okay,
oocytes,
okay.
it is only seen when 7 that got fertilized, 3 got unfertilized. So it is again a cause.
But it is more common in when it is TFF in IVF, then we resort to ICSI.
Yeah, that is basically a rescue technique which is to be done on the limited time period of duration. That is the rescue ICSI. And
And
that,
in next cycle also we can take the patient for ICSI.
no,
We
yes,
should.
yes. If we have seen fertilization failure with IVF, that IVF embryos, that IVF cycle didn't turned out into any embryo, and then in that particular cycle we need to do rescue ICSI, then yes, in the next upcoming cycle we need to pre-plan with the ICSI preparations.
What is rescue
Thank you.
ICSI?
Rescue ICSI is basically doing ICSI at the time of fertilization assessment, when this conventional insemination or the natural IVF didn't worked well. In that particular situation, rescue ICSI helps, but it will also eventually reduces the chances of good quality embryos, or it will also reduces the chances of implantation potential for embryos.
So after 17 hours, when we check for 2 p.m., then rescue ICSI is attempted.
Then yes, then rescue ICSI is attempted.
And if you're saying that like ICSI, if after ICSI fertilization failure, what to do for next cycle?
Then for the next cycle, it is basically recommended to use artificial oocyte activation, these chemical products to be used in that particular cycle. And then at least we should process for embryo formation, and we can expect good quality embryos. Shall we proceed with the next presentation, or anything else need to be asked or said, or we can discuss many other things?
So one question, what are nucleolar precursor bodies?
Let me get back to the presentation here. Can you see the screen?
Yes, sir.
Here you can see there is a pronucleus. There are the two pronucleus. One is the bottom and one is at the top. In this particular pronucleus, you can see these small circles. Can you
Yes.
see?
Yes, sir.
Yeah, these small circles are the nucleolar precursor bodies. These are basically the compressed form of genetic material, and eventually with the fusion of pronuclei, the genetic material also fuses. So that role is just in form of fertilization or in terms of fusion of genetic material. That's it. How many of you have the experience of working in lab, or you have been already posted to centers, or it's only online going this year?
Sir, 8 among us are embryologists and 8 among us are clinical
Oh,
clinicians.
that's great. Okay, so we'll be starting with the next topic, that is the genetics of male and female infertility. Basically, it is a very broad topic to cover in just small minutes of time. I have tried my best. With the development of ART techniques, there is rapid expansion seen in investigation of genetics for male and
Sir,
female.
we cannot see your slides.
Okay, just now is it available? Now is it seen? You can see?
Yes, sir.
Thank you. Okay, so with the development of ART techniques, a rapid expansion has been seen in investigations for male and female infertility genetically. This allowed at-risk couples to take pre-informed decisions before conception. It is already speculated that around 15% of male population and 10% of female population from that infertile couples of infertile cohort of patients are subjected with genetic abnormalities. So going back to the basics, what is the definition of infertility, which is very well known to all of us? That is, it is the failure to conceive after 1 year of regular unprotected intercourse. Yes, and at that particular set of infertile conditions, our goal is to evaluate and identify the cause of infertility, to prescribe the adequate therapy, to provide the accurate information to the couple, and with that accurate information, yes, it is our moral responsibility to provide emotional support during due time or post evaluation and the treatment. There are the various elements in infertility evaluation, and we might not be discussing each and every one of that. We'll be focusing on our topic, that is the genetic evaluation. In that particular genetic evaluation, our strategy must be very simple and sweet, that a couple must be considered as a single unit, as each partner contributes a share to infertile potential. Many couples may have more than one contributory factor or the cause, which would be identified either early, that is the best way to find out it early, or in later stages that may be not good for us or for the couple also. So going back to the genes and genetics of human, that is the genome. Human genome is basically comprised of gene, which is the basic unit of inheritance. Genes are organized on chromosomes, and in human it is like 22 pair of somatic autosomes chromosomes and 1 pair of sex chromosomes. And out of that, 6 million base pairs and 20,000, only 20,000 genes that are available to encode protein. Rest is either regulatory or junk. So back to the basics. In this particular slide or picture, we can see how the chromosomal abnormalities arises. In the natural way, there is a phenomena which is basically done in a pre-designed manner, that is the balanced chromosomal rearrangement during the process of fertilization or during the process of meiosis or gamete development. And here the DNA eventually encodes protein, and then the functioning is being done. And in the abnormal situations where there most of the imbalances seen that can be due to the gain of extra set of chromosomes, gain of the partial set of chromosomes, loss of set of chromosome, or loss of a scale of chromosome, and it can be due to improper amplification, or it can be due to the deletion of a portion, that is the portion of or a portion of a set of chromosome is deleted. This particular image represents how the abnormalities being seen, that in this portion, yes, deletion removes a segment of chromosome, yes, and this particular segment is now missing. In duplication, there is an extra set of segment of chromosome is there, inversion and translocation. So these basically these chromosomal abnormalities basically have their role, or somehow they are responsible for impacting or inhibiting or inheriting genetics to infertile couples. And this particular assessment can be done at the following stages, which is the preconception state, where the male and female partner are individually analyzed, both with the each and every form of assessment with the genetic assessment as well. It can be done on pre-implantation level, where the embryo is formed in an ART lab, and that embryo is being sent to a genetic lab, and then the assessment is done, and then the transfer is being done. Or at the prenatal state, where the fetus, where the pregnancy has already been occurred, and that fetus is now allowed to process for genetic testing. So coming to male infertility, yes, it is already evident from literature that sperm has its impact over embryo development, not only on early stages of embryo development, but on to the later stages of embryo development, including the implantation rates, pregnancy rates, and miscarriages. Yes, sperm is responsible. And what makes these sperm cells of more interest? Yes, these sperm cells are not a limiting factor. There is a genetic uniqueness seen in each and every sperm with the different variety of phenotype. Spermatogenesis is a continuous process. Spermatogenesis is a continuous process where spermatogonia, a single spermatogonia results into 4 motile sperms. And with this spermatogonia, it also divides mitotically to increase the self number, and the chances of chromosomal aberrations or anomalies goes high on high. I was searching the internet and got this image where spermatogonia develops into spermatocyte, spermatid, and spermatozoa. Each and every spermatogonia result into 4 good quality motile sperms. Just look at the picture and imagine the number of genes involved in this particular process. At each and every set of situation, many genes are responsible for proper functioning and getting good quality spermatozoa out of that. So coming to the basics, the hallmark for evaluation of male infertility is the semen analysis. It provides a detailed information on routine basis. Yes, abnormalities in sperm production or function or alone in combination with other factors that accounts in 30 to 50% of all infertility cases. Semen examination is basically being done macroscopically, microscopically by looking at the volume, appearance, and every phases of liquefied semen, and microscopically with seeing the sperms with concentration, motility, morphology, and how the agglutination means how the clumping of sperms is there. So each and every aspect is being seen, and WHO has given a huge impact on cutting out or giving out lower reference values of all the seminal parameters, which helps in actually determining the infertile and the fertile population of males. The lower reference values of 2010 are mentioned here. There is a rule of semen analysis and the presentation of chromosomal anomalies. If the semen analysis report is with oligospermia, with this particular oligospermic patients, like around 2 to 9% of the patients may or may not exhibit chromosomal anomalies. It is being said that these set of patients may exhibit structural abnormalities, and in patients where we see azoospermia, like they exhibit around 2 to 7% with the chromosomal abnormalities, and these abnormalities are basically with the sex chromosomes. And mainly what to be seen in the sperm is the acrosome content. Generally, a semen analysis report doesn't reveal what is there inside the acrosome or what is there going with the acrosome. So for that, a unique set of technique or a unique set of test available there in the market, which revolves around looking at the sperm DNA fragmentation. So what causes impaired sperm DNA integrity? That can be due to age, exposure to chemicals, or exposure to extra heat, idiopathic causes, other various causes that can be damaging to the sperm DNA. And these sperm DNA damage that can basically inhibit or exhibit at various levels of outcome, where the embryonic outcome is basically halted, or poor outcome is seen in IVF or in natural cycles as well. So indications for sperm DNA assessment that can be done in cases of unexplained infertility, repeated ART failures, recurrent pregnancy losses, predictions of for ART outcomes, post chemotherapy, advanced paternal age, where the chances of having damage in genetic integrity of sperm is almost higher, or at the highest point of damage can be seen. There are many assays available to assess sperm DNA integrity. The most common or most current area, this is the most current area of investigation. Sperm chromatin has been demonstrated to be packaged very differently from chromatin in somatic cells, as there are many ways by which it can be done. It can be done, or detection of sperm DNA damage can be done via comet, tunnel, sperm chromatin structure assay, or the halo test, which is the most commonly used and available form in market, that is being done in almost 1 to 2 hours of sperm processing. And with a simple halo formation, we can determine, yes, there is a DNA fragmentation or not. These DNA fragmentation tests uh, are mainly dependent on checking. They checks around oxidative mediated stress. Elevated sperm DNA fragmentation is associated with infertility, poor ART outcomes, and recurrent miscarriages. Ultimately, if the value is like less than 15, then it can be termed as a good prognostic value, or the chances of having good outcomes is can be seen in that particular set of situation. So the question arises, or the question would have been there in each and every us of our mind, that are these sperm DNA tests useful as a diagnostic or prognostic clinical test? For a DNA test to be useful, it must have a strong predictive capacity for pregnancy outcome, and it should little overlap between the fertile and infertile samples. I may not go deep into each and every set of genetic causes of infertility, but yes, the major causes for that affects genetics of a male population is the changes in chromosomes, changes in numbers, or chromosomal aberrations, or gene mutations. These are basically defined in a paper which was published in 2002, that is in European Journal of Human Genetics, which stated that these particular genetic defects or causes can be seen with the male infertility. And the tests which are available that can be done, basically and the foremost is the karyotyping, and then comes with the genetic level of assessment. Even the aneuploidy screening, which is the aneuploidy analysis of spermatozoa with fish, that is also correlated with the sperm DNA fragmentation, that can also be done as a genetic test or the counseling tool for male infertility. Furthermore, a number of genetic disorders may affect spermatogenesis, but clinical manifestations are so complex that infertility represents a minor feature. Some forms of male infertility characterized by uniform and permanent morphological or structural alterations of onto the entire sperm population and are probably due to the results of unknown genetic mutations. This aspect should be kept in mind during the counseling session with a couple who are undergoing ART treatment, or any couple who would have been trying to conceive, or being infertile for a year. So this to be kept in mind before proposing any treatment methodology. So switching to the female portion of infertility, that is the female infertility has also been classified primarily on clinical criteria, abnormalities of ovarian function resulting in abnormal menstrual cycle. Even if recurrent fetal loss is there, it is not actually a cause of primary infertility. It has been included given its clinical relevance and frequency of genetic causes in these conditions to be analyzed and assessed before the patient is allowed for next conception. As the process of spermatogenesis goes, the same with the oogenesis. In females, the proliferation of oogonia occurs prenatally, hence the female reproductive lifespan is limited by the number of oocytes in the initial pool, the rate of which deplete as the age increases or as the ovulation years go on and on. So, and only 1 out of 4 meiotic products from oogenesis becomes an ovum, and remaining 3 of the other meiotic products turn out into polar bodies and later degenerates and gives all their help to the expanding cell, that is the oocyte. Oocyte basically feels all the changes, and these changes are also caused due to the luteinizing hormones that changes the tissues, and within the follicle goes the swelling is seen within the follicle due to increased hyaluronan content. Matrix proteases later degrades, and the natural cycle goes on with the egg and surrounding cells ejected into the peritoneum, and then the ovulation occurs. But what differently we need to see is there are the number of genes responsible for all this event from oogenesis to the ovulation. And yes, this synchronized working or the synchronized situation is needed, not only physiologically, not only biologically, chemically, biochemically, yes, genetically also. Then only a good quality or a healthy oocyte is being ovulated and later fertilizes to form an embryo. And going with the maturity status of an oocyte, first the oocyte matures nuclearly, means the nuclear maturation is seen, and then followed by the cytoplasmic maturation, which covers the rest, where the organelles, other proteins, or the other cytoplasmic contents are there. Following the progress of molecular biology, and many studies have been undertaken in recent years to clarify the genetic mechanisms underlying female reproductive disorders. Apart from chromosomal abnormalities, alterations, female sexual maturation or reproductive function may be the cause of gene defects at various levels. Moreover, the possibility of single or multiple gene defects in common clinical conditions that can be seen in PCOS, polycystic ovarian syndrome, or premature ovarian failure. Technical progress in ART have been stimulated the research of genetic in the field. As a consequence, some clinical aspects specifically related to these techniques are such as poor ovarian stimulation response. And finally, a relationship between has been established between many chromosomal abnormalities and spontaneous early fetal demise, which is ultimately the cause of genetic cause of female infertility. And the same paper which we discussed earlier, that also stated different sets of conditions, genetic conditions for female infertility that are also related with the chromosomal aberrations, gene mutations, and chromosomal aberrations which are confined to oocytes as well. That is the advanced age. That also has an huge impact or huge role in causing the deformity or poor quality of oocyte formation. Again, the tests available for genetic testing for female infertility. So before proceeding, there is a need for careful diagnosis of infertile status, the evaluation of risk for the child to be born after the assessment, and the appropriate management for pregnancy needs to be planned, not to consider all possible genetic causes of disorders. Each and every set of technical aspect to be checked or to be assessed separately. Genetic counseling should be offered to all couples undergoing genetic testing, and it is further strongly recommended when a genetic anomaly is found in either of the couple. The final decision or the final thought should be left on the couple that regarding whether they need to proceed for the conception or not. Again, in summarizing, yes, the assessment can be done at the preconception, pre-implantation, prenatal level, and at particular level whenever the evaluation or the assessment is seen, the patient to be counseled at the same time and to be checked and corrected the same way. The final conclusion is the genomic basis of infertility is very complex and is determined by many factors. These factors can influence either at level of gamete, organ, physiology, or at embryonic development stage. The couples with infertility problem should be informed of all available genetic tests, the reoccurrence of genetic predisposition to their offspring, the available procedures for genetic predisposition, and ultimately the thing which needs to be done is the proper counseling and the patient to be handled appropriately and properly with the assessment and with the infertility evaluation.